full के लिए अरे अंडरस्टैंडिंग ओके सर அவர்தான் அன்மியூட் பண்ணணும் இல்லடா அவர் வந்தப்பறம் அவர் அன்மியூட் பண்ணுங்க சார் வரணும் வரல இதுல போட்டோ மேல போட்டு வச்சிருக்காரு
हेलो हेलो हाँ लॉगिन तो कर दिएছি
राजीव संतोषम
शुरू हो गया बुझले हेलो हाँ तो बातें করছি
फिर अभी
Bolo Hospital လေဒီဘိုးတော်ကြီးဆိုရင် Santosham Hospital အခုအိန္ဒိယမှာသွားပြီးတော့ liver transplant တွေသွားလုပ်တဲ့ဆေးရုံတွေလေသူတို့ကလုပ်တယ်ဒီဘိုးတော်ကြီး
ये मेल इंदने उंगले इंद ट्राई பண்ணலாம் சார் இந்த நம்பர் அதுதான் சார் सिंगल मोटर इट्कोंडु पो सर ಏನಪ್ಪ ಸಿಂಗಲ್ ಮೋಟರ್ ಹಚ್ಚುವ ಸರ್ ಅದಾ ஆமா ஆமா ಸಮೀರ್ ಮೋಹನ್ வரಲಿ
Hi sir, good evening.
Hello Samir.
Hi, how are you sir?
Can you see me?
Yes, I can see you very well sir. Thank you. How are you doing sir?
I'm fine, but things are not that good in India.
I know, I heard. Yeah. I heard that it is on the rise actually. That's
yeah.
It's a very worrying.
Yeah.
Oh my God. Let's hope that things settle down. But today they said in the liquor shop, so there is a lot of queue for liquor in India. There's some serious jokes coming on WhatsApp about that situation. You're keeping well, sir? Are you getting fed up of sitting at home?
Voice ಜಾಸ್ತಿ ಅಲ್ಲ ಜಾಸ್ತಿ
Can you hear me, sir?
Yeah, I'm very loud and clear. Yeah, I'm good.
Sir, one thing I said, whoever is setting up your computer, bring your computer close to you, sir, because your volume then gets picked up much better if you're close to the. Because the other day we were getting a little bit of echo, but this when you came close, the answer it was very clear, sir. So is Rajiv going to be sharing? I can see Rajiv is.
Rajiv is here. Rajiv.
but I seem to be sharing Rajiv's screen. Are you on two separate screens, is it?
Yeah. Sorry?
Are you on two screens? Because one is your video, which is coming in, but also your screen share is coming from another computer. Have you got two computers on?
No, I'm not on any other phone or computer.
Okay, just one computer, is it? So let me just, okay, I'll swap it around. All right. Okay, got that. How are you keeping, Rajiv?
Good, sir. How are you, sir?
I'm all right. How's your daughter?
Yeah, she's doing good.
Doing good, huh? She must be the star role in your life.
Correct.
Wife and daughter, yeah? I saw your DP. Is that with your daughter? Huh? She's
Yeah, that's my daughter, sir.
Yeah, I saw she was wearing a sari. I said, wow. She's grown up.
She's 10 now. Yes.
Oh my God. Dr. Santosham told me, Dr. Rajan told me once that, take care of your children. They grow up very fast. Before you know it, they're gone.
Yeah.
Spend some time with them. So I'm taking it seriously now. So we've just got another couple of minutes, sir. We just wait. Actually, 1 minute more. So then we start on time. Is that okay?
Can you hear me, Zamir?
Yes, sir. We can hear you.
Yeah, very good.
How long is your talk, sir, today?
This must be about 20 minutes, I think.
Oh, is it? Okay. So we'll have a short session.
Half an hour.
No, that's all right. That's all right, sir. We will have a short session today, I think.
Yeah.
Normally, yesterday I did clinical governance, audit, and consent and things like that.
Yeah.
Went on for 2.5 hours, sir.
My God.
It was a very good discussion, actually, for the exam-going people particularly. They need to know
Okay.
all the theory behind it. And also all the various cases and all. Okay, sir. So let me first start recording, if that's okay with you. So good evening, ladies and gentlemen. Welcome to yet another session of Thoracic Gurus. As promised, we have again with us Professor Rajan Santosham, who's kindly given us his time, and he's ready to share his experience, probably one of the largest in the world in terms of surgery on tuberculosis and surgery for thoracoplasty. Sir, could you please start your presentation? But before you start, can I request everybody to please switch off your microphones, please? Sir, I will switch everybody off, and then you will have to switch your microphone on. Is that okay?
Yeah, mine is on.
Yeah, but I'm going to switch everybody off in one go, and then you switch yourself back on. Okay, you're on, sir.
Can you hear me?
Yes, sir, we can.
Yeah. Thank you, Zamir, for the kind words. Today, I'll be speaking about thoracostomy and thoracoplasty. Is there a role in the present-day thoracic surgery? Open window thoracostomy is a treatment for chronic pleural empyema in which a surgical drainage opening is created in the chest wall, done for patients with post-pneumonectomy bronchopleural fistula who are very ill. May be the only option in patients unfit for other major surgical interventions. Open window thoracostomy helps to control of sepsis and improved ventilation with reduction in air leak from the fistula is usually achieved. May function as a temporary measure prior to a more definitive treatment of the fistula, and also leads to a significant reduction in pleural space or even closure of small fistulae. It's done for very ill patients. Open window thoracostomy may be sometimes permanent. With daily dressing, without necessary hospitalization, control of sepsis and adequate ventilation can be achieved. And of course, well-being of the patient. The surgical technique, position usually in the lateral decubitus position, a double Y-shaped incision centered on the ribs to be excised. 3 short segments of ribs are usually excised between the anterior and posterior axillary line. The stoma should be sited just low enough to allow adequate drainage. This is how it is done. The ribs are excised and the skin is sutured to the underlying pleura so that you get a final thoracostom. I'll give you a classical example. This is a case. 27-year-old male had confirmed tuberculosis, started on anti-TB drugs for 6 months. Later developed a bronchopleural fistula and empyema. In 2011, had decortication and closure of fistula. 2012, right pneumonectomy, and then developed space infection, bronchopleural fistula, and open drainage done. In 2014, anterior thoracostomy and bronchial stump closure with diaphragmatic and parietal pleural patch. It then had air leak on the 6th postoperative day. In 2015, had sternotomy, right bronchial stump reclosure, now with omental transposition and space closure with muscles. Unfortunately, this also failed, now presenting with a large thoracostomy opening and an anterior small opening. You can see the midline sternotomy incision and the thoracostomy wound. There was a bronchoscopy picture, showed a large bronchopleural fistula with a suture material that you can see. This shows that the entire bronchoscope could be passed through the BPF and seen through the chest cavity. This is a CT. Now we come to thoracoplasty. Thoracoplasty is resection of short segments of ribs as a means to collapse therapy for apical tuberculosis. Originally, this was done for apical tuberculosis. This was first described by Serenville. The term thoracoplasty was coined by Estlander. At the end of 19th century, measures were introduced to collapse or obliterate the diseased cavitating lung. This was the pre-tubercular, chemotherapy era, and this was the time when my father practiced TB, medicine, surgery, and radiology in Chennai. Carlos Forlanini introduced artificial pneumothorax. This was followed by other methods of collapse therapy. Thoracoplasty was a radical method of collapsing the lung. The principle of thoracoplasty, removal of part of the rigid chest wall skeleton and resection of the ribs, ensuring the collapse of the chest wall and eventual closure of an infected pleural space. This collapse, the wall of the cavity, favors healing by fibrosis and obliteration of the space. Various collapse procedures were practiced. I have participated in most of them: phrenic crushing, artificial pneumothorax, pneumoperitoneum, plombage, thoracoplasty, and finally came the Jacobius thoracoscope. Was originally meant for cutting adhesions by thoracoscopy to ensure good collapse of the lung. This was the artificial pneumothorax used by my dad. During my early part of my career, me and my brother have also used this. Early days, before the anti-tubercular chemotherapy, it was the treatment of choice for tubercular cavities. Thoracoplasty in early days was used to be done under local anesthesia. I myself have done with the help of my dad and afterwards independently Thoracoplasty under local anesthesia. No double lumen tubes were present at that time, and the cough reflex had to be preserved to avoid spillover of TB, which was a dreaded complication. Current indications of thoracoplasty include multi-drug resistant cavitary disease with endobronchial disease unsuitable for resection, hemoptysis with poor respiratory reserve, empyema post-tubercular or pyogenic, bronchopleural fistula in which other procedures have failed, post-pneumonectomy infections. Stage thoracoplasty. With an underlying functioning lung, it is always preferred to do thoracoplasty in 2 stages because if more than 5 ribs are removed, it can lead to severe paradoxical respiration. Thoracoplasty can also be done as a single stage procedure in post-pneumonectomy empyema since there is no underlying functioning lung and no paradoxical respiration. In situations with active TB, destroyed lung with infected pleural space, bronchopleural fistula where decortication will not be possible, BPF are closed either by intercostal muscles or by omentoplasty, which is not always done in a thoracoplasty. In some cases, you have to do it. Tubercular cavities are mainly located in the apical segment of the upper lobe and the posterior segment of apical and posterior segment of the upper lobe and superior segment of the lower lobe in the posterior-superior aspect of the lung. It is necessary to do costotransversectomy and apicolysis for best collapse. Total number of cases are about 1,622. The mortality is fairly low. The period is between 1964 to 2020. It was under local anesthesia 356, single stage 877 and 2 stages in 745. Second surgery and completion pneumonectomy in 6 patients. Thoracoplasty failure in 32 patients and pulmonary hypertension in about 1% of patients. Thoracoplasty for post-pneumonectomy empyema, you can see the large space, empyema space. You can see the bronchopleural fistula as well. Normal left lung. Completed thoracoplasty and a good collapse of the lung. I'll show you an interesting case. 32 years of age, presented with complaints of air gushing out through his chest wall for the past 4 months post right upper lobectomy. He was operated elsewhere for this complaint of air leak 2 months back by reapproximation of the upper lobe stump. You can see the upper lobe space in the apex, and you can also see the good collapse after thoracoplasty. Bronchopleural fistula, a 32-year-old male with recurrent hemoptysis with a destroyed right lung. Right pneumonectomy was done, developed bronchopleural fistula, window thoracostomy and BPF closure using momental flap followed by concomitant thoracoplasty. This guy lives in Calcutta. In fact, he's phoned me up this evening just before this presentation. You can see the entire destroyed lung on the right side, massive hemoptysis, compensatory emphysema of the left lung. You can see the compensatory and the destroyed right lung. with shift of the mediastinum to the right. This again shows cavitatory disease. Large momentum was harvested, and the momentum has been used to close the large bronchopleural fistula. You have seen interrupted sutures to close the fistula. This is the post-operative picture. Yeah, this is the next case showing you ICD in position and left pneumonectomy bronchopleural fistula. You can see the CT pictures. You can see an intercostal muscle closure of the bronchopleural fistula. The next patient, thoracoplasty, was done in 1979 for hemoptysis, and later it recurred. It was a two-stage thoracoplasty for which bronchial artery embolization was done in 2008. The problem persisted and it came with massive hemoptysis, and completion pneumonectomy was done in 2009. This is you can see the two-stage thoracoplasty scar. You can see the collapsed lung and hemoptysis and contracted left lung. Picture taken after completion pneumonectomy. These are difficult operations because already the lung is fibrous, the lung is collapsed, and you have to sometimes do an intrapericardial ligation of the pulmonary vessels. Finally, this guy has done well. He is an auto driver and he's still able to drive his auto. In conclusion, at present, effective medical treatment for tuberculosis and widespread use of antibiotics have largely limited the use of chest wall collapse therapy. However, tuberculosis, MDR and XDR, and non-specific pulmonary and pleural infections still a serious problem in many parts of the world. In conclusion, a comprehensively trained thoracic surgeon, especially in a country like India, should be familiar with the technique of thoracoplasty. It may still be a preferred option in some particularly difficult situations, especially in cases of the failure of accelerated treatment of post-pneumonectomy MPM. Now I'll show a short video.
Upper lobectomy for post-TB bronchiectasis. You can see the airspace in the left upper lobe and also the two scars. They attempt to close the fistula, but it was a failure. He developed a bronchopleurocutaneous fistula. The incision for thoracoplasty is a long J-shaped incision in between the scapula and spine over the third rib, coming below the scapula along the sixth rib up to the anterior axillary line. After the incision is extended into the intercostal muscles, the scapula is lifted off. The periosteum overlying the rib is incised and separated using a periosteal elevator and dissected circumferentially of the ribs. A Doyne's elevator was used to remove the periosteum from the anterior and the posterior part of the rib. The ribs are cut posteriorly and anteriorly. Posteriorly, it is cupped up to the costotransverse process. This is because most of the TB lesions are in the posterior segment and apical segment of the upper lobe and superior segment of the lower lobe. This gives maximum collapse. The pleural space is opened through the bed of the resected rib, and the pus and debris are removed with suction and curettage. While using the curette on the medial side of the pleura, The surgeon should be cautious not to injure the pulmonary vessel stump. The extent of rib resection is determined by palpation of the pleural space. It is convenient to remove the lower ribs first, as the resulting collapse of the ribs gives access to the second and the first rib. The first rib is usually not removed, but the periosteum over the ribs is pushed down. While doing so, you have to be careful not to injure the subclavian vessels and the brachial plexus. Adequacy of collapse should be assessed at every stage to avoid excessive thoracoplasty. Fewest possible ribs are removed. Epicolysis. The lower ribs have been removed. Periosteum over the first rib separated. Epicolysis done by pushing the pleura from the rib, at the same time protecting the brachial plexus and the subclavian vessels. I learned thoracoplasty under local anesthesia from my late father, Dr. Madhuram Santosham, who was a TB specialist in India. He started the lung clinic in 1936, Santoshapuram TB Sanatorium in 1946, Santosham Chest Hospital in 1976.
Zamir?
Yes, sir.
Yeah, that is a completion of the presentation, Zamir. Yeah.
Okay, sir. Thank you very much, sir. It is so exciting to see this talk. Always learn something new every time I listen to your talk, sir. Sir, can we start with some question and answers, sir?
Sure.
Okay. The first and foremost is, while you're doing a thoracoplasty, do you use muscle flaps or omentums within the pleural space to close the fistulas?
Not always.
Do you need to combine?
Not always, but sometimes yes. It depends on the size of the fistula, and it depends on the bronchoscopy, CT assessment. If the fistula is large, I usually use either intercostal pedicle and sometimes, as I've shown you, omentum patch, but not always. Not always.
Okay. Now, with the newer medicines coming in, and the tuberculosis becoming more and more a medical treatment rather than surgical treatment, do you think thoracoplasty will become obsolete, or do you think it's a procedure that will stay?
Now, with the advent of good anti-TB drugs, you get early diagnosis and effective treatment. However, there is a small group of patients who do not have resistant XDR and MDR TB and also have endobronchial tuberculosis, and they are not fit for resection surgery. These are the cases which will benefit with surgery, and of course empyemas. But the role of thoracoplasty has come down significantly, but it is not obsolete, because in selected individuals, it is an effective tool to treat the patient and make them well. I still see thoracoplasty patients operated by my dad 50 years ago. They'll be 80, 85. Some people even with bilateral thoracoplasty still coming happy and healthy. So it has got a role, and at present the role has come down, but unless you know how to do it, know how to select the patient, the results will not be good. So careful selection criteria is very, very essential in this setting.
Okay. Now, starting in 1964 to 2020,
Yeah.
how many cases a year did you do in the earlier series, and how many cases
Yeah,
a year
I
do
won't
you
be
do
able to
now?
exactly tell you, but
Just
definitely,
an approximate.
definitely about 75 patients of the cases would have been done in the first 15 years.
I see. Okay. And so
75.
now in a year you
It's
do.
becoming less and less.
So what are we talking? 10 cases a year, once a month, or is it?
Yeah, less than once a month now.
Oh,
Once
less
in
than
2
once a month.
months. Once in 2 months. Some months
So-
we may have 3 cases, and 3 months we may not. Average once in 2 months.
And that is because TB medical treatment has become good. Is
Yeah,
that
very,
why you
it's
think
very
that's
good
happening?
medical treatment, even for your second line drugs, you have good supporting drugs.
Okay. And what is the cause of thoracoplasty failure? You said there was a certain segment who had
Yeah, see,
thoracoplasty
they
failure.
have flare up of disease, they have persistent hemoptysis, they have opposite side infection and respiratory failure. These are the, and of course pulmonary hypertension. These are the, but the numbers have been quite few because we have selected them very carefully.
So what do you do when the thoracoplasty fails?
It's a very difficult question. When they develop failure, they can become respiratory cripples. They can develop opposite side infection, hemoptysis, and we are left with only treating them symptomatically and palliatively with medicines, anti-TB drugs and supportive drugs.
Okay. And you said you have done patients with bilateral thoracoplasty.
Yeah.
What is the effect on the respiratory function of a thoracoplasty? And as an extended question, bilateral thoracoplasty.
See, most of these patients cases have been done in young, healthy individuals. And as I told you, even as guys who have done 50 years ago are coming still healthy and happy with bilateral, but I can't generalize. It is a difficult problem. And those days they didn't have anti-TB drugs. They didn't have anti-TB drugs. That's why they had to do, in selected cases, fit young individuals, bilateral apical thoracoplasty for young patients with TB. Because anti-TB drugs, after advent of anti-TB drugs, bilateral thoracoplasty has lost its role.
So in the present, you spoke earlier about using a window as a tool for draining out the pus.
Yes.
What is the effect on the quality of life of
It
a
is
patient?
very, very poor. Nobody likes to have a window. These people are very sick, unhealthy patients who are not able to stay in the hospital for long. And the window thoracostomy is clearly explained to them, and not everybody will accept a window thoracostomy. Most of them want to be left with a tube. But some of them say, why don't you see? Because it will be dramatic. The pus will completely drain, granulation tissue will form, and the whole empyema cavity will become smaller and smaller. So it is, the quality of life is very poor. It's clearly explained to the patient. Most of them do not want it, and some of them want it, and a significant number of them have done very well.
In terms of the sequence of the disease, how do you time thoracoplasty?
See, thoracoplasty in the pre and chemotherapy era was different. This in a patient with cavitary disease, a reasonably young patient, unsuitable for resection because of significant endobronchial ulceration and scarring, and not responding to anti-TB drugs and even the second line drugs and the third line drugs, who have persistent recurrent infection. These are the cases which need with underlying functioning lung. That is when there is an underlying functioning lung. We have done quite a few even now, but the numbers are not very many, and they have done very well. And of course, the empyema is common. post-tubercular empyema, post-pneumonectomy empyema, it can be done as a single stage also when there is no functional underlying. You must understand quite a few of patients, post-tubercular patients, you cannot do an effective decortication from the effectively because of very severe thickening, underlying disease and the thickened pleura entering into the parenchyma. If you try to do a decortication in such patients, the air leak becomes more. So instead of bringing the lung to the chest wall, you bring the chest wall to the lung to collapse the empyema cavity.
Sir, is there any role for the newer vacuum suction drainages and things for tuberculous cavities? Instead of having a window thoracostomy, could you possibly put in the vacuum pumps into the chest?
I've not done it, Zamir. I've not done it, and I'm not the good person to talk about it. I think I've been happy with this. Patients have been happy, and I've not tried that.
Okay, sir. Could you explain to the youngsters the difference between the two terminologies? One is Elozere flap, and the other is Claggett window. So, in the exam, how can they sort of describe the two things, and what is the difference?
Claggett window is what I showed you, an open window, and you irrigate the window. In an Elozere flap, you combine it with a partial thoracoplasty. The window is combined with a partial thoracoplasty, whereas that cannot be done in very fit patients. And this one, what you do is, in Claggett's procedure, you go on washing the cavity carefully when there is if there is no BPF, otherwise they'll aspirate. And as you go on doing it, you fill it up with gauze. Take it periodically and clean it, and they heal much faster.
Sir, in your presentation, I saw a patient with a chest drain with a safety pin attached to it. It brought back memories from my previous experience where we used to do this thing called a shortening of the drain with a safety pin pushed across the drain. So what is the indication for that, and do you use it at all nowadays? Or is
no,
it given
now
up?
we don't use it, Zamir, but sometimes the patient don't want a bag. It's a glorified thoracostomy. They don't want to go home. So nowadays we are not using it. I don't know how you used it. When did you use it?
That was in Plymouth, Derriford with...
Which year?
Many years ago, sir. During my early training with Joe Rahamim. Dr. Rahamim used to do that for empyemas, where he used to leave in a drain in there and put in a safety pin. And then every week we used to reduce the drain by 2 centimeters or a centimeter. So it was called a shortening of the drain.
It is still being practiced.
I have not used it in my clinical practice personally, but definitely when I was training, I have seen it being used. Guys, can you switch off your phones, please? Hello. Please switch off your phones, guys. This is very disturbing for sir. Sorry, 1 minute, sir. I'll just switch off some people's phones. Okay. I will now ask the questions from the audience, sir, one by one. Give me a second. I'll just bring them up. So, sir, what is the reason for removing the periosteum of the rib before removal of the rib?
See, what happens is when you don't remove it, you push it off. And what happens is, after 3 months, a new rib forms. And the stability of the chest is well maintained. Because once you leave the periosteum and the collapse is good, the new rib forms at that level and stabilizes the chest.
Sir, what is the technique and indication of tube thoracostomy?
Tube thoracostomy is a glorified intercostal tube drainage. That's all. There's nothing more than that. It's a glorified intercostal tube drainage.
Okay. So again,
tubes, and some of them want this so that they can go home and just dress it by themselves.
Again, I think you've already answered it, but I will ask, sir, what is the ideal timing for performing thoracoplasty after chronic pleural empyema with BPF?
The ideal time will be first to drain it, improve the nutrition of the patient as far as possible, and toxicity of the patient with antibiotics, and give him at least 3 to 6 months time. And still after that, if there is a significant space for post, that is the time when you do.
Sir, which patient with tuberculosis empyema with BPF goes for decortication with closure of BPF, and which one goes for a thoracostomy?
See, when you know that the patient has got significant underlying parenchymal disease, when you do a CT, you see the thickened pleura and lot of cavities underneath. Those patients do not withstand a decortication because the BPF will definitely become poor. We will see puckered areas in the pleura, calcified areas. Those patients will initially need a thoracostomy. And decortication is out of question. And after some time, the chest wall is brought to the wall of the pleura by thoracoplasty.
And what is the role of intrapericardial pneumonectomy?
Intrapericardial pneumonectomy especially comes after when there is severe hilar adhesions, especially post-pneumonectomy, completion pneumonectomy. Once you open the pericardium, you can easily, there's no adhesions, you can go around the pulmonary vessels, pulmonary veins, and then the amount of bleeding also becomes significantly less. So those are the cases in which you, in redo surgery with a lot of hilar adhesions, because already you have dealt with the hilum, pulmonary stump, everything. So once you take, and nowadays we use staples when you do intrapericardial ligation. And then after that, the surgery becomes much easier and the blood loss is much less.
Sir, you spoke about sternotomy and transpericardial bronchial stump closure. Could you just tell us when you do it and how you do it?
To be honest with you, I have not done it. I've read it in books. I have seen some patients who have had it. You just do a sternotomy, clear the pulmonary vessels, especially for a right bronchial stump, and then clear the bronchus, and then use a stapler to see. But I have not done it. Have you done it, Zamir?
I have done one case. Bal has presented a series of, I think, 8 or 10.
Okay. I've not done it.
Yeah, but I've done one case actually. Okay, sir, is there a role of TB sanatorium in current day medical practice?
There is no role for a TB sanatorium in the current day practice. Initially, sanatoriums were built near hills where there is a lot of fresh air, good nutrition, they are given good food because no anti-TB drugs were available. Now with the advent of good anti-TB drugs, most of the patients can still go to work and take anti-TB drugs. They don't need that acutely, except in acutely ill patients, they don't need the hospitalization and sanatorium type of care. I've been to my dad's sanatorium during the early part of my career, and we used to have about 60 patients there who stayed for a month, 2 months, 3 months, and some of them still come. But there is no role for sanatorium care in the treatment of tuberculosis. This has been accepted world over. Most of the sanatoria have been, different type of hospitals have been started in them. Different nursing homes have been started. They were very popular, and most of the rich people went to Switzerland. In fact, I think Nehru's wife also, if I remember right, went to a sanatorium in Switzerland. So that was the treatment those days.
Sir, is Santosham Chest Hospital situated within the city or outside on a hill?
Right in the center of the city.
Oh,
that's why you have to.
So it was not designed as a sanatorium.
No. The clinic was there, OP, outpatient. See, now We get acutely ill patients who come and stay for a short time and go. No patients stay for a long time. We take all precautions and do the cases. And we have not had, it's not like COVID.
Sure.
Not like COVID.
Sir, what's the cause for pulmonary hypertension after thoracoplasty?
See, what happens is the space gets obliterated and the respiratory reserve goes down, and just like post-pneumonectomy in pulmonary hypertension, a small percentage of them develop pulmonary hypertension. Same principle as post-pneumonectomy pulmonary hypertension.
Sir, could you tell us again about a staged thoracoplasty and what is the time interval between the two stages?
The first stage, you do the patient, you do usually the first, second, third, and fourth ribs. Usually, those days we used to remove the first rib also, then give a 12 to 15 day gap and do the second stage. Keep them in the hospital, do the second stage, and after that you discharge them.
Through the same incision?
Same incision.
I see. Okay.
To prevent paradox, we used to strap the patients. We used to have a special sort of bandage which used to strap them.
Okay. In an Elozar flap, how many ribs are resected and what length?
It depends on the size of the empyema. Depending upon the size of the empyema, you resect. Whereas in a Claggett procedure, you usually remove 3 ribs and make a thoracostomy open.
So long-standing chronic empyema space with BPF, who is planned for thoracoplasty, after periosteal resection of the ribs, draining and debriding the empyema space, pleura is so thickened that we are unable to collapse the pleura. How do we go about these scenarios?
The pleura need not be collapsed. The chest wall comes down. The chest wall is pushed inside. Pleura doesn't come out. The chest wall goes in and obliterates the space by the collapse. And I told you about epicolysis also, which is very important, to push the pleura down so that it falls.
Okay. After lobectomy, how do you time intervention in persistent space after lobectomy?
See, as long as the patient has no fever, no hemoptysis, no infection, you just leave that space alone. It's not going to trouble him. You should not interfere. Whereas in a situation where there is recurrent infection, recurrent hemoptysis, recurrent space problems, and toxicity, that is the time when you have to intervene. Because most of the cases after lobectomy in inflammatory disease, you will have a small space. You don't chase that space and go and do something unless the patient warrants it by his symptoms.
If a patient presents with post-tuberculous empyema, could you tell the audience what are the steps to manage it?
See, the first step is just to drain it. You'll be surprised to know that post-tubercular empyema, about 80% of them heal with just intercostal drainage and good anti-TB. It is only the 20% who have a large bronchopleural fistula, who have a thickened pleura, who are not, the lung is not able to come out and expand, and anti-TB drugs are not effective enough to clear the infection in the lung. These are the patients who need the intervention. After that, you assess the parenchymal disease in the lung. If you think the parenchymal disease is not significant, then you can definitely try decortication. On the table, if you feel this patient, the lung will not come up, you can do a concomitant thoracoplasty or only thoracoplasty. So it's a combination of things.
Sir, Dr. Samir Bhate has done 2 cases of sternotomy and bronchial stump closure.
Okay.
And he says that the anatomy is quite challenging as it is distorted. Samir, can you switch on your microphone and share your experience with us, please?
Yes, sir. So I was referred 2 cases of closed pneumonectomy bronchopleural fistula, where there was a long bronchial stump. I think the right bronchus was, there was a long bronchial stump, and that's why it had resulted into a bronchopleural fistula. So the anatomy was so distorted, the heart had almost gone onto the right side. So there was no way I could have gone in and attempted to do anything to the bronchial stump. And that person was very miserable because she had a tube in, and then they had done a a Lozer flap. So that is the reason why she was a young patient. So she wanted that to be closed. When we went in through the sternum and went in through by retracting the right side, the pulmonary veins, and I had to do a completion pneumonectomy because she had a right upper lobectomy done initially, and then I had to do a completion pneumonectomy for it. So it was quite a difficult procedure because I could feel the bronchus, but the bronchial anatomy was so distorted that I really struggled to get hold of the bronchus. But ultimately, I was able to do it, and all went well.
Okay, so this was
not nothing much surgically I can share, because there is no set anatomy and there are no landmarks in such a case. But intrapericardially, I felt that I was easy. It was handling, or rather getting rid of or ligating and dissecting the pulmonary veins and the pulmonary artery was easier. But the bronchial stump, going towards the bronchial stump is slightly challenging.
Sure. So this access was through the thoracotomy rather than transsternotomy?
No. This was through sternotomy.
Through sternotomy.
I did extend it on the right side just to get a proper exposure of the bronchus, because the mediastinum had shifted quite a lot on the right side. So that is why I had to just take an extension on the right side. So it became sort of a hemi-clamshell on the right side.
Okay. Thank you very much, Samir. That's very helpful. Thanks.
Thank you.
The next question for you, sir, is in post-operative period following thoracoplasty, what kind of compression dressing is done to approximate the decostalized chest wall to the underlying pleura? How long do you place the compression dressing?
This was done mainly for patients with stage thoracoplasty, because even after the first stage, they can go in for paradoxical respiration because there is an underlying functioning lung. There used to be a special bandage which used to be used. It used to have multiple layers coming anteriorly, posteriorly, 2 straps in the neck coming down, and then you completely tighten it and strap it. That was the strapping that was done.
So nowadays, I'm the one who does the dressing. What I do is I put a lot of pads, surgical pads on the area where the collapses, and then put the dynaplast, multiple dynaplast crisscross.
Oh, I see. Okay. Sir, your take on short-term ATT regimen versus older long-term regimen and your experience?
See, I'm not at all an exponent of the short-term regimen, because I've seen a lot of patients who had very good early disease, who are failures of this short-term regimen, who have come to me. In fact, people from corporation come and also talk to us and tell us about the start. I said, I'm not convinced in it. They can go to, I'm not at all convinced about the short-term regimen. Weekly, twice tablets doesn't work. You have to take care of these patients when they come, give them daily medication. First 3 months, INH, streptomycin, pyrazinamide, and rifamycin. After 3 months, take off the streptomycin and the pyrazinamide and give them 9 months treatment. That is a full-fledged treatment. 90%, 95% of them get well. Instead of that, if you do bi-weekly treatment and a small regimen, the number of bacilli which becomes resistant becomes more and more. And quite a lot of failures I have seen. If since you asked me, this is my personal experience.
Sir, do phrenic nerve crush is still performed?
No. I have done it in the early stages. It is not.
Okay. And post-pneumonectomy with BPF, how would you manage, sir?
Post-pneumonectomy BPF, immediately drain it, reduce the toxicity, assess the size of the bronchopleural fistula by a good quality CT and bronchoscopy, see the edges. And invariably, most of the cases, it is difficult, but you are able to go in and fix the fistula, use omental muscle flap, and if the space is still big, do a concomitant thoracoplasty.
So the next question is very nice, sir. It says if you do an open window thoracostomy, you're creating an open pneumothorax. So what is the pleural mechanism? How does it work?
By the time you do that, the mediastinum is fixed. The mediastinum is fixed. There is no way the lung can collapse. It's a fixed space. It's a fixed space. The question of pneumothorax doesn't occur. So already it's a fibrous fixed space.
Sir, we have Dr. Diwan with us as well. Can I ask Dr. Diwan to switch on your microphone and please tell us about your experience with thoracoplasty, with Claget's window and Elozar flap, and you were going to say something about the daily regimen of anti-tuberculous therapy.
Good evening, sir. Good evening, Zamir. Thank you for being here. Can you hear me?
Yes, sir, we can.
I broadly agree with what Professor Santosham has. As far as daily regimen is considered, the intermittent regimen was introduced earlier because of the operational difficulties. But after 2013, even Indian authorities have been recommending daily regimen of ATT. So short-term regimen, but nobody is prescribing twice weekly or weekly regimens. The authorities also, the standards of TB care in India. Number two, about thoracoplasty. You asked about, yeah, thoracoplasty, I do the same way as Professor Santosham does. And we do it mostly for residual spaces as well as those with bronchopleural fistula, those with diseased lungs or post-operatively. In addition, we do thoracoplasty sometimes, as I told in my lecture, for treating primarily the space, the cavities at the apex in cases of drug-resistant tuberculosis and cases of hemoptysis where surgery is not feasible. Otherwise, as far as Elozar flap goes, it's an excellent operation for those cases of chronic tubercular empyema, which are a huge number in our country, who are not fit for decortication and in whom the lung parenchyma or architecture is so diseased that even if you do a very good decortication, the lung will not expand. So leaving an open window thoracostomy makes the patient immediately get rid of all the toxicity present, the pus which is present, and he becomes quite non-toxic within 3 to 4 days and can manage an open window thoracostomy at home. And gradually in 70 to 80% of the cases, the whole space closes off. The bronchopleural fistulae close up, the lung expands, the chest obviously contracts on that side, but overall healing takes place. And following that, thoracoplasty can be added to completely eliminate the pleural space and heal the chest wall sinuses. So these are procedures which, though are slightly mutilating, but overall they provide a very good relief to these patients. Yes.
Sir, considering that you run the National Institute, the TB program in the National Institute of Tuberculosis, over the years that you have been in service, how has the numbers changed in terms of thoracoplasty? As sir said, he used to do a lot before, but one every 2 months. So what is the feel for the audience? How many cases are you doing, sir, previously and now?
See, previously, suppose in 1990s, we were doing thoracoplasties much more. Over a period of time, the number of thoracoplasties has decreased, not because the number of cases which are requiring it have reduced, because of better understanding in our own management of these cases. And I believe that thoracoplasty should, because it is a mutilating procedure, should be a last resort. An open window thoracostomy should be given a chance in the beginning, at least, in cases of chronic tubercular empyema. So number of thoracoplasties overall has definitely shown a significant decrease in our practice. But despite a reasonably successful anti-tubercular program or whatever is going on with the complexities of our society, the number of patients requiring thoracoplasty still has not become zero. It is still in our own practice, for at least in our national institute and government setups, it is roughly 10 to 12 a year, sometimes more than that, 30 also, up to 30 also. But generally it has reduced to 12, 15 in a year.
And what were you doing previously in the peak of the practice in the early 1990s?
Early 90s, I joined the TB Institute in 1992. And from 92 to 97, we had done 139 thoracoplasties and we had published a result. So there has been a decline over the
so there's definitely been a decline. Why is it that the Western world doesn't do thoracoplasty, whereas Southeast Asia does a lot more thoracoplasty? This is a question for both, sir, Dr. Santosham and for Dr. B.
See, the pattern of disease they see there is different. And the way you'll be surprised, in Russia, they still do. The incidence of TB is very high. And Diwan has gone to some East European countries where he has helped in TB surgery treatment, where but the incidence in the West has come down significantly. They see it mainly in the population of repatriated Indians, Pakistanis, Bangladesh. But the local people, as you also will know, the incidence of TB and post-TB sequelae is very much less. And, this, so our patients are different from all over the country. Now, of course, Diwan will be able to see better. The incidence is definitely coming down. There's no doubt about it. And, but there are definitely the incidence of surgery has not come down totally. We have selected patients who definitely do much well with the combination of surgery than pure medical treatment. So that is without any doubt that has been established.
So is it true to say, the question that I'm asking is, do you need to do thoracoplasty more in TB patients or in MDR TB patients or in XDR TB? Does it matter? Does it differ? What is the data on that?
Yeah, I would rather do it in MDR or XDR with significant endobronchial disease, which is not suitable for resection. That's it. That is my take on. And Zamir Diwan joined the institute in 1992, and 13 years later, I had to retire from government service. So I have started. See, what happened was, in my case, my father was a TB surgeon, and one fine day he suddenly became a member of parliament. So he taught me how to do thoracoplasty and local anesthesia, and left me to do it. So I had to do all these procedures initially under local with a good friend of mine called Dr. Vijay Shankar. That's how we started. I've also told this to Diwan, but Diwan, by the time you came to your institute, had anybody done thoracoplasty under local in your institute?
So, because of the availability of good general anesthesia, we always do it at a general anesthesia, but one case we had done under local anesthesia.
Okay.
One single case. I have experience. And
when I went to Australia in 1982 or 83, I had my personal series, not my dad's, 100 cases of stage thoracoplasty under local anesthesia. After that, it became very much less because of the problem of, by the time 92, everything is set for Diwan. But earlier days, it was different. It was a completely different. See, if a patient was put in the lateral position, with an active tubercular cavity. If it infects the other lung, he will die. So that was the reason to protect the cough reflex and do it. And you'll be surprised, these patients did so well after local. I myself am a proof for that. You will never believe it. We used to go on injecting local layer by layer, no diathermy. Eat silk, no catgut cause severe, autoclaved silk. Cotton silk, linen. And some of them developed sinuses. Most of them got well. It is an amazing journey in thoracoplasty, which I have gone through right from the earlier days. See, what I used to do is, when I was in school, I used to go with my dad and stand in his side when he did surgery. That is how I picked up the interest. When I was, say, 12 years, 13 years, every time I had an opportunity, I went with him, sat in his OP, and also went to the sanatorium to see him operate and assist him in operation. That is how the journey was for me. It was something I had to do, and something I love to do. And I definitely selected thoracic surgery over cardiac surgery because of that.
Now, sir, because we are on the topic, I just want to ask you, your journey has been sort of with your dad being a TB surgeon, you carried on doing the cases. Now with Rajiv doing so much of VATS and, all the advanced cancers and things like that, what has Rajiv's experience been in thoracoplasty? Does he believe in it?
No, Rajiv,
does he do
I will
it?
pass it on to Rajiv. Nowadays,
yeah, I'd like to hear him to say
10 years, I have not done a single case of thoracoplasty. Everything Rajiv only will do. He will tell me,
I see. So,
you stand on the others, you sit in the stool, I will do it. He will answer that.
Okay.
When Diwan came, Rajiv was not there. When Diwan came to Santosham, Rajiv was not there. But now, he's mainly there, and I'm just a sidekick.
Thoracoplasty is kind of a difficult operation to do physically, sir. It hurts, going through especially when the ribs are crowded and everything. You have to go between the ribs, go around the ribs, subperiosteally, and break it. And it's a painful operation, but the results are very gratifying. I'd like to say, very, very gratifying. Most of them have done very well.
I see. Okay. Dr. Diwan, would you tell us about your experience of Eastern European versus India? Why thoracoplasty is done more in the Southeast Asia and not so much in Russia and Eastern Europe? They have similar diseases, but they don't do as many thoracoplasties. So
the Institute of Physiology in Moscow, I went there in 2009. They still have a considerable number of thoracoplasty. In fact, I have a difference of opinion with them. Some of them do it where I will not do it. Because what they do is, suppose they are operating for multi-drug resistant tuberculosis and doing a lung resection surgery, they will do an upfront thoracoplasty along with the lung resection. While I feel that this is too much of a procedure, it is not necessary. You can just do a resection, and if the patient does not develop complication, he may get away with doing a thoracoplasty. And I do it only if the patient develops bronchopleural fistula or empyema which needs thoracoplasty. While Russian surgeons will do a pneumonectomy along with thoracoplasty. And recently there was a publication in which they were described a minimal access approach of doing thoracoplasty. It isn't published recently.
I read that, sir.
2015 onwards. Kracher, somebody called Kracher.
I've read that.
Minimally,
they still do
thoracoplasty.
Yes,
minimally invasive thoracoplasty in Russians. I don't know how far. I've not seen it, but
I've not seen it.
A couple of them, and they were telling that they are doing it. In one of the ESTS meetings,
Yes. So they're still doing it.
We have Dr. Bharadwaja, who actually wants to share a video of post-pneumonectomy empyema, which opened through the main wound. I think if it's okay, sir, we'll ask him to share his screen. Sir, switch off your screen sharing. Rajiv, switch off your screen share. I'll do it if that's okay. Okay. And Dr. Bharadwaja, did you want to start sharing your screen? It is a green button at the bottom, and you can tell us about it. Hello. Hi, Dr. Bharadwaj. Are you still with us? I don't know if he's there or not there. Maybe he got a bit upset because I took a bit of time to get to him. Dr. Bharadwaj, are you still with us?
Yes, sir. Yes, sir.
Did you want to share your case, please? You have to share screen from the bottom. There's a green button at the bottom. Give us a feedback, Dr. Bharadwaj. We don't know if you're listening to what I'm saying. Okay, I think we are getting no response from him. Okay, so I think overall it's been a fascinating journey, sir, that you've had over the years. I mean, 1964 to 2020. It's even before I was born, sir.
I know that. I don't tell this to too many people.
So it's just
1964 was the year I joined MBBS. And from that time, I had been with my dad whenever I could. He used to go at 5 o'clock in the morning to the sanatorium. And any time I had free, my brothers will laugh at me. Why are you going with our father? But I had a dreaded interest, and that's how I started learning Thoracoplasty. And when he became a politician, I had to do it. I had to run the hospital, sanatorium as well.
I think.
Can I add one
yes,
thing here?
Yes,
actually, because of the historicity of the procedure, I remember a case which I saw in 2010. His thoracoplasty was done in 1969 in my institution when I was not there. So it is, and he was still doing well. He must, that thoracoplasty was done at the age of 23, 24 years, and he was in his 60s now. And
That's
yet
exactly what I'm saying. I see even people with bilateral thoracoplasties done by my dad, who will be about 75 years old now, 70, 75, they come, and I should have got some of those pictures. And I can keep it, yeah.
Okay, I think Dr. Bharadwaj has just started screen sharing. So let's see if he can show us his case. You have to start your PowerPoint or wherever your video is. But you have to remember that on Zoom, the resolution of videos is not very good at all. So it's not as you can see it on your screen. It's always a very disjointed thing with videos. I personally believe, sir, that this video that we are making, this recording of your talk, is going to be like one of the gems. Really, it is going to be gems, and we are going to, view it long after you have gone. People will continue to see this and remember you. Sir.
Thanks,
I really believe this is going to make a huge.
My father's will be rolling in his grave in whatever it is left, or from heaven to hear.
Absolutely right, sir. Absolutely right. I mean, what an amazing journey, sir. Dr. Bharadwaj, are you sharing with us, or are we going to call it a day? I can see some activity, but no. Okay, I'm going to stop recording, sir, because I need to maintain this video very well. Okay, thank you very much. I think we've had no joy with sharing Dr. Bharadwaj's videos. So thank you very much, sir. It's really always a pleasure to interact with you. I just love it. Every time I talk to you, I feel as if my dad is there, sir. I lost my dad very early, but every time I meet you, I really get such I get a peace deep inside my chest, sir. I get peace deep inside my chest. So thank you very much. Rajiv is very lucky.
Make your son a thoracic surgeon.
My son wants to do finance, sir. He doesn't want to do medicine. Economics and finance. The young generation doesn't.
What about your daughter?
She also doesn't. She's an artist, sir. I don't know. They haven't spoken about medicine as yet. But thank you very much. It's such a pleasure to talk to you. And thank you, Dr. Diwan, for your deep insight into the subject. I think we all learn a lot every time we listen to all these doyens of thoracic surgery. And as I've said before, whatever we are today, we are because we are standing on the shoulder of giants. And it's really giants like you, like Dr. Diwan, like Dr. Babatosh, who have completely changed the impact of thoracic surgery in India. And I think now the new people are choosing thoracic surgery as a first choice rather than
absolutely. See, at
as
one time, thoracic surgery used to be in the last table in the teaching hospital. Nobody wanted to go.
Yeah.
I used to get an anesthetist, get him a packet of biryani, sit and did coloplasties, resections, everything, thoracoplasty. But after some time, after the days went by, at one stage, what happened? The cardiologist started taking away most of the surgeon's work. Now, a lot of people have realized that and want to do thoracic surgery, especially with guys like you around who come and show all sorts of jazzy things, videos. So things have changed a lot. Thanks to you, Zamir. Thank you for the role you are playing in Indian thoracic surgery. I see the face of Shilpa Gandhi there. Every meeting she is there. Encourage all of them, bring them up. And of course, Diwan has been. Diwan, can Diwan hear me?
Yes, I am there very much. Yes.
Situation in Delhi, Diwan.
Yeah. The situation is serious, sir. The number of cases which have been recorded today have been much more than yesterday. Even the deaths also in COVID. And in addition, I may say that today, Government of India, from the lockdown, they opened up wine shops, and the social distancing norms were thrown to a wind. Well, several people came to buy alcohol and liquor.
Yeah.
Zamir, I wanted to make one more point. You see,
yes,
we believe that Western countries do not do thoracoplasty, but I have occasionally met thoracic surgeons from all parts of the world who have been doing thoracoplasty, including South Africa, Italy, Spain, France, off and on, or at least they had seen earlier in their career. And if you remember, when Yugoslavia broke up, then the number of TB patients in that area increased. And I have a feeling that COVID also is going to lead to a lot of socio-economic disruption all across the world. And the number of TB cases and whatever is resultantly required, this may unfortunately increase further.
Zamir, I wanted to add one point. They had invited me to the World Chest Wall meet in Norfolk. I was surprised with the number of surgeons in South America who are doing thoracoplasty, and Russia and places like that. But rest of North America, Canada, some of the guys call me even then, thoracic surgeons, when they have difficult situations and get advice on what to do, regarding thoracoplasty and things like that. So I think some of them are doing it, but not commonly, but sporadically. Any case which you do sporadically, you don't get to get better. For you to, by God's grace, to get better in any particular type of surgery, God must bless you with more cases in that field. That way, Diwan and I are very fortunate as far as TB surgery and thoracoplasty is concerned. And thank you very much for the nice meeting. I thought we'll be over in almost 1 hour and 20 minutes. So,
excellent,
very nice discussion we had.
I think it's just amazing to.
How many more sessions are you going to have?
Today, I had promised everybody that I would stop at 52. Today is the 52nd one.
Okay.
But I think there are still more topics to go, sir. We have still
what are the topics, Amir?
We are not going to let you stop.
I've got a board.
He couldn't. He is not able to resist.
Sir, I will just show you the board. I don't know if you can see it, but I've got a board with all topics on the thing. So
we'll make a century.
I don't know, sir. We'll try and do as much as we can, because what I think is, if we can have everything, all topics in one place, then it becomes easy for the youngsters to revise, and in future also they can use these for their revision.
Are you recording these talks, Zamir?
All of these are recorded.
Okay.
all of them are put up onto YouTube, onto a
Very good.
channel called as Thoracic Gurus. So
Okay.
everybody's talks are there. So today is the 52nd one, sir. So I think we've done
At
well.
least during COVID days,
I know.
kindly spend some time with your wife and children. Please. Spend some time.
She is telling me that I am more busy now than I was before I was traveling.
That I told you that. Okay.
Yes, sir. Yes, sir. You're right. I will tell her that. So
But
tomorrow,
one
no
thing,
classes for
one thing,
8:20.
Zamir, Diwan also, even though we have so many COVID cases in India, the death rate is not that high when compared to the West or America or England so far. In Chennai, they have 2,000 cases. Number of deaths are 31.
Yes.
Number of hospitalized cases are very much less. I think that is a pattern also in the rest of the country. I think because of our immunity, BCG vaccination, heat, maybe it has developed some change and it is not as aggressive as it. What about your experience? You would have seen some of your friends get it, and how has it been in the UK?
Oh, UK is very bad, sir. Very bad. The healthcare professionals have paid a very high price for this disease, and you know, a lot of doctors. As I told before, personally, I know of a transplant surgeon, a cardiothoracic surgeon, a hepatobiliary surgeon. So a lot of big shot guys have died, unfortunately. And nurses are paying the price. But the one thing that we are noticing consistently is that Black and ethnic minorities are more affected than the white the Black and the Asian population.
Asian population. Okay.
Yeah, we are paying a higher price than the white population, and that is true even in the USA. That the Black and ethnic minority is more mortality. So we don't know what is happening. There is that is why the reports from India are more surprising, because in the Western world we are completely the opposite. Whereas in India, I thought you would have had much more mortality than what is being reported.
In Chennai,
so the question,
31 only have died. Chennai, even though we have so many cases.
So two questions which I think I want to ask Dr. Diwan, because he's involved with this epidemic quite a lot, is number one, is it a different strain that you're having in India? And number two, do you think it's because of under-reporting and under-testing that the numbers are less?
See, most of us thought that in India probably the impact would be less, but I am still having double thoughts about it, because today recorded the maximum peak again. We had the new cases reaching 4,000 today only, and also the mortality of today, which was reported as 195, which is much more increased as against yesterday. So they are still early days, and because lockdown is opening up, and a very strong lockdown from Indian standards, the kind of lockdown that has been imposed is unprecedented and is reasonably successful lockdown across the country. But now it is being opened, so we still do not know. And as far as mortality goes, though it appears on surface that we have lost less number of cases, but it is still reasonably quite high for any infectious agent to have consumed so many people in such a short duration of time. As far as the strain goes, it may be the same strain. It's only because our population is younger, it has lesser number of comorbidities, so mortality may be lesser. The epidemiological profile. Still too early for me to have a rosy picture. It's as scary in India as in West Africa.
No, I think India is going to have a higher peak. I think with the movement of migrant workers now starting in the trains, and I think that is going to spread far and wide. And definitely with this today's news of the alcohol shops opening up and 1 kilometer, 1 mile queues, and nobody keeping social distancing, it's really worrying. I think once the government pulls back on the social distancing norms and the lockdown, I think it will come back with a vengeance. That's my feeling on it. I don't know whether you agree or not.
Let's hope you're wrong, Zamir.
I hope I'm wrong. I really hope I'm wrong. I really hope. I mean, it's a real concern. But the important thing, sir, is life is not going to be the same.
This is going to stay for a year or 2 years. We have to live with it. We can't be just inside lockdown all the time. We have to, sometime in life, we have to see and be practical as well. We can't close our lives totally.
Sir, I did a talk for these youngsters on financial management for young surgeons.
Yeah.
And one of the messages which I put out to them was that you cannot have all your eggs in one basket. You've got to have small income, but from multiple sources. And it is something that is so important. I mean, like I have a medical legal practice as well, as does my wife. And I'm telling you, sitting at home now, the income is coming in now from another completely different stream. The medical legal practice has suddenly gone up dramatically. And, I'm sitting in my office just before I started this lecture. I consulted about 8 patients and these are all highly paying, source of incomes. So what I want to tell the youngsters is that things are going to change. Life is not going to be the same anymore. We can't think that, we'll be going to hospitals and making, adequate incomes and things. Job losses are coming into the picture in a big way. So we have to all prepare to because the future of our family and future of our children are on the line, and we have to make sure that we make some arrangement for them. And any one of us can get COVID. That's the bottom line.
I know.
That's the reality. So I think it's important for the youngsters to think laterally and have multiple sources of income, not just one source. And I in my lecture, I gave them lots of points on how to go about doing that. It is very important that we talk about financial management with the youngsters, because I think the world is definitely going to change. Job security is no longer a reality. It's no longer, even your own practice, sir, you will see there must be a huge drop in the numbers, isn't it?
Absolutely.
I'm sure.
Absolutely.
So it is important for youngsters to think of all these things. Anyway, thank you very much, sir. And it's really been nice to talk to everybody. I think these lectures have been like a lifeline. We can reach out to everybody and feel like we are part of a family, sir. So the evenings have been well spent. Okay. Thank you very much, everybody. And I will call an end to the meeting. Thanks.
Thank you.
Thank you.
Thank you.